Well, very good. And like I was saying earlier, you're not going to find a more qualified physician than Dr. El-Atfy in this area. Back to sleep apnea, is there such a thing as a typical sleep apnea patient?
Well, I cannot say typical sleep apnea patient, but of course we have a slide that we can show the audience about, let's call this patient as Mr. X. And Mr. X is a 42 years old man with 10-year history of loud snoring, which drives his wife crazy and drives her out of the bedroom as well, and is causing marital discord. He awakens with snoring and occasionally is aware of brief gasping upon awakening. Despite going to bed earlier and napping more, he is always tired. He feels sleepy throughout the day. He falls asleep whenever sedentary, including at work and while driving. And he almost had near collisions on account of his excessive daytime sleepiness. His employment requires frequent and sometimes long drives, and his memory and concentration, even libido and patience have all decreased. There has been a gradual weight gain of over 40 pounds over the past 12 years. And he noticed more nocturia, which meaning increased urination at night, waking up to urinate, and reflux symptoms and dry mouth at night. So this is a typical case of a sleep apnea patient. So that's Mr. X. That's usually the complaints that the patient might come to his physician, primary care physician, and complaining about, or the spouse would be complaining of him snoring, or the spouse had witnessed several apneas while the patient is sleeping.
Well, and you mentioned several symptoms related to sleep apnea.
Right.
So what are some of the risk factors related to sleep apnea, and maybe some other symptoms?
Definitely. Well, the most common risk factor would be snoring. Of course, snoring is prevalent in the U.S., actually in the rest of the world. It's up to 55% of the U.S. population snore. Not necessarily that all patients who snore have sleep apnea, but the reverse is true, meaning that patients who have sleep apnea, all of them, they snore. So that's one of the most important risk factors. Other risk factors would be obesity, which is again endemic in the U.S. Of course, the higher the body mass index, like more than 30, increased risk of sleep apnea. Other risk factors like neck circumference, for men, if it is more than 17, and for females, for women, if it is more than 16, that's another risk factor for sleep apnea. Other risks for sleep apnea would be drugs like sedative drugs or alcohol, or upper airway abnormalities like craniofacial abnormalities, which cause a narrow space at the back of the throat, increased tendency for sleep apnea to occur.
Okay.
And the symptoms, if you are asking about the symptoms, as I mentioned with Mr. X, the most common symptom would be, of course, the loud habitual snoring, which is in a way a telltale sign for us as physicians and even for the spouse that there might be some problem related to breathing when the patient sleeps. Other symptoms would be non-refreshed awakening or excessive daytime sleepiness, and this drags on during the daytime. Frequent awakening at night, like sleep fragmentation or sleep disruptions, or going to the bathroom, as I said, frequently to urinate. Waking up with dry mouth or gasping for air or sense of choking, that's a very specific symptom with sleep apnea. Waking up with morning type of headaches. Of course, like foggy mind or loss of concentration or attention throughout the day. It affects the patient's work and daily activities. So it interferes not just at night while the patient is sleeping, but it interferes with his daily activities and work-related activities. In addition to, it can cause some social problems as well.
Well, very good. We're going to come back in just a few minutes and go into a little more detail about sleep apnea, how it's diagnosed, how it's treated, and how we can help you at the Santa Rosa Sleep Disorder Center at Santa Rosa Medical Center. Be right back.
Santa Rosa Medical Center is pleased to announce the opening of its Santa Rosa Sleep Disorder Center under the direction of El-Atfy, MD. Dr. El-Atfy is board certified in pulmonary medicine, critical care, and sleep medicine. The Santa Rosa Sleep Disorder Center is located on the Santa Rosa Medical Center campus at 5992 Berry Hill Road, Suite 204 in Milton. It's equipped for the diagnosis of sleep disorders in a safe, comfortable, hotel-like setting. For more information about sleep medicine at the Santa Rosa Sleep Disorder Center, please call 877-232-2717.
Again, welcome back to the Santa Rosa Medical Center show. We're talking about sleep apnea with Dr. El-Atfy, pulmonologist at the hospital. Dr. El-Atfy, just keeping it simple, exactly what is sleep apnea?
Well, sleep apnea is a part of a spectrum of diseases called sleep-related breathing disorders, which include obstructive and central sleep apnea and periodic breathing, like Cheyne-Stokes breathing, which usually occurs with patients who have congestive heart failure or renal failure or strokes, and nocturnal hypoventilation, which usually occurs in patients who have obesity, hypoventilation syndrome, or patients who have neuromuscular diseases. But obstructive sleep apnea syndrome is the most common type and the most prevalent in the U.S. population and the rest of the world. As I mentioned before, part of that due to the obesity as a huge risk factor. Obstructive sleep apnea syndrome is a mechanical obstruction at the back of the throat. Normally, the throat is surrounded by muscles. Those muscles actually control the way we speak, the way we breathe and swallow. Of course, while we are awake, those muscles are active. But when we sleep, the muscles at the back of the throat actually get less active and relaxed. And the back of the throat tends to narrow a little bit because of the relaxation of the soft tissue and the muscles at the back of the throat. So if there is an increased tendency to have sleep apnea, if the patient has tendency with the risk factors that I mentioned to develop sleep apnea, then it will create problems. But most of the people will not have any problem breathing-wise, even with the narrow throat at the back of the throat, because of they don't have those risk factors that I mentioned. If the patient has the tendency to sleep apnea, what happens is as the space in the back of the throat gets narrow with the soft tissue and the relaxation of the muscles, the airflow gets diminished a little bit. And of course, as you get deeper in sleep, the muscles get relaxed more and increase risk of snoring. And what is snoring? Snoring is the vibration of the soft tissue at the back of the throat, the soft palate and the uvula. And when air goes into a narrow space, those soft tissue vibrate, and it creates the sound of snoring. As you get deeper in stage and the muscles get more relaxed, the snoring gets louder. If the back of the throat collapses, meaning shuts down, it's just total collapse of the soft tissue, that's when the obstructive apnea occurs. It is complete cessation of breathing for a brief period of time, maybe 10 seconds. That's the definition of an obstructive apnea event. Some patients have obstructive apneas. Some other patients, they don't have complete obstruction at the back of the throat, but just what we call obstructive hypopnea, which means diminished airflow at the back of the throat. There is a little bit of a space, but it is very narrow, and it allows air to flow, but it is just very diminished airflow, and usually associated with low oxygen saturation as well. And that's what we call obstructive hypopnea, associated with low oxygenation at night. Of course, when this happens throughout the night, and it's a repetitive occurrence, occurring multiple times throughout the night, and of course every night, and over the lifespan, over many months or many years, this creates problems, because whenever there is a period of apnea or hypopnea event, there is a lack of oxygen in the blood. And of course, the brain sense that there is no oxygen coming to it. So what the brain does is it sends an alarming signal or arousal signals, which basically the brain would like the patient to wake up and resume breathing. So instead of the patient having a restful night and sleeping and the brain relaxes, the brain has to be active, has to send those arousal signals so that the patient will resume breathing. Some patients will actually wake up completely and not knowing why they woke up. They think that they might have an urge to go to the bathroom, and that's what they woke them up, but it's most probably the apnea event which woke those patients up. So a little bit about sleep stages, because this is very crucial when I'm talking about obstructive sleep apnea. Whenever we sleep, sleep stages is divided into two categories: REM sleep and non-REM sleep. The REM sleep, which is the dream phase or dream sleep phase, comes in cycles every 90 to 120 minutes. The non-REM sleep, which is divided into stage 1, 2, and 3. Stage 3 is the slow wave or delta sleep. It is the most relaxing part of the night. Those two cycles alternate, the non-REM and REM. If the patient has periods of apnea preventing the brain from reaching deeper stages of sleep, what happens is there is interruption of the continuity of sleep. And instead of the natural shift of stage 1 to stage 2, stage 3, and then REM, the patient stays on stage 1 or 2, which are lighter stages of sleep, because of this frequent arousal signals or awakenings on account of the periods of apnea, interrupting the sleep stages. During those brief seconds, the burden on the heart and the brain is significant, because those lack of oxygen to the brain, it increases risk of strokes by 4-folds. Lack of oxygen to the heart, especially the conduction, the electricity of the heart conduction apparatus or circuit, it can increase risk of abnormal heart rhythms like atrial fibrillation, and increase risk of lack of oxygen to the heart muscles, increase risk of MI, and even increase risk of death. And there is a multitude of systemic diseases that we will touch base later on regarding the comorbidities or the complications of sleep apnea if it was left untreated. Of course, when this interruption of continuity of sleep occurs repetitively, as I mentioned, and the patient wakes up, whether he or she notices that they are waking up, or if the spouse notices that the patient is waking up because of snoring loud and then quitting breathing, the patient will feel tired in the morning because there's no restorative sleep. They feel that they never had enough sleep, and they never reach deeper stages of sleep, and this drags on during the daytime. So whatever happens at night when the patient sleeps affects the daytime. And of course, as everybody knows, we spend a third of our lives sleeping. So sleep is very important in our daily functions.
Yeah. Well, and obviously very serious situation. What's the process for diagnosing sleep apnea and just how bad it is?
Sure. Well, sleep apnea diagnosed by having the patient have a sleep study. This sleep study could be done in a sleep disorder center, or could be a home sleep study. But preferably it's done in a sleep disorder center, where it will be an attended sleep study, because there will be a sleep technician waiting for the patient, and the patient will go to the sleep center around 8 p.m. and the patient will be connected to monitors, electrodes from head to legs, because there were different types of electrodes, like EEG electrodes to check for the different sleep stages, and electrodes around the eyes to check for the rapid eye movement sleep phase, nasal pressure transducer to check for the airflow, a small microphone chip on the chin to check for snoring, strap on the chest and the belly to check for the respiratory efforts, and 2 EKG leads to check for the heart rhythm, as well as a pulse oximetry to check for the oxygen saturation while the patient is sleeping, and electrodes on the legs to check for leg movements, what we call periodic limb movement disorder, or restless leg syndrome. So the patient will be connected to a lot of wires, but those wires are very soft and pliable, and the patient can roll in bed without any problems. It will not interfere with the patient sleeping at night, and the patient even can wake up, go to the bathroom without any problems connected to those wires. So that's basically a diagnostic study. So the way the patient should be worked up or evaluated is if the patient notices that he or she has a problem at night, or if the spouse notice that there is a problem at night, they should discuss this with their primary care physician, and the primary care physician can either directly refer the patient to have a sleep study, or if he elect to refer the patient to a sleep specialist for initial consultation, and then the sleep specialist will refer the patient to have the sleep study based on the initial consultation. So that's the way we diagnose sleep apnea.
Dr. El-Atfy, once you've been diagnosed with sleep apnea, how is it treated?
Well, of course, once the sleep study is done and the sleep study is scored by a registered polysomnographer, I will read the sleep study, and if it came back as positive for sleep apnea, then we ask the patient to come for a second night in the sleep center for the treatment night, which would be the CPAP titration study. CPAP stands for continuous positive airway pressure, and what we do is we put the mask on the patient and we titrate the pressure. We start with a low pressure setting and gradually titrate the pressure up, and our main objective is to eliminate snoring and respiratory events and to keep the oxygen saturation above 90%. CPAP works it's an air pressure machine. It provides air under pressure, air from the atmosphere through the hose, through the mask, and what it does, it's like a pneumatic splint. It's like an airway stent to keep the upper airway open. Once we determine the pressure support setting that will be adequate for the patient as a treatment, that will be the prescribed pressure setting, and the patient will have different types of masks to fit his or her face, and then the patient will be followed in the clinic within 4 weeks to make sure that the patient is compliant on CPAP, and if there is any difficulties or any problems, then we can always address it in that appointment, and I can work with the patient throughout the course of especially the first 3 months or 6 months to make sure that the patient is compliant with the CPAP and feels comfortable wearing it every night at least 6 or 7 hours. So that's the way we treat sleep apnea.
Very good.
Of course, there are other surgical and oral appliances approaches, but the most effective is the CPAP therapy.
Dr. El-Atfy, just how prevalent is sleep apnea in our society?
Up to 26% of the U.S. population have obstructive sleep apnea syndrome, and the incidence is up to 9% in women and up to 26% in males. And as I mentioned before, snoring is up to 55% of the U.S. population are snorers, but not all snorers have sleep apnea, but the reverse is true. So, and of course, 85% remain undiagnosed.
That's been very educational. I know, like I said, my wife has punched me many a night trying to get me to wake up and or go back to sleep and quit snoring. But it's Dr. El-Atfy said it's a big problem, a lot of other risks. I want to thank Dr. El-Atfy for coming on and sharing his expertise with us. If you've got a situation with sleep apnea or sleep disorder that you'd like to talk with us, Dr. El-Atfy's phone number and information has been on the screen. Love for you to come out and see our Sleep Disorder Center. Beautiful bedrooms where you can sleep at night, and we'd love to have the opportunity to take care of you out at the Santa Rosa Medical Center. So again, thank you for watching, and we'll see you next time on the Santa Rosa Medical Center show.